outstanding expert from the Vienna and Yale University to give us a lecture, and the session will be moderated by Professor Jidong Jia and Professor Sima Alam. So thank you for joining us, and now I would like to invite the moderator to keep on moving to this session. Thank you.
Okay, so do you want me to start, Dr. Manoj?
Yeah, you can introduce Professor Ferenczi then.
Okay, so hello everybody and good evening. Professor Ferenczi does not need any introduction. The introduction is that he's a teacher, and I can make out from the fact that he just told me few minutes back that he has not been keeping well, but he's here with us. At this time, he's here with us and ready with his lecture. So Professor Ferenczi has been a professor of the Medical University of Vienna, Austria, and has published more than 600 papers. He has been awarded the APASL, Achievement Award, and also he's been a champion gastroenterologist by the World Gastroenterology Organization. So, and we know that Professor Ferenczi and Leipzig score, these are kind of synonyms for most of us. So here's Professor Ferenczi.
Well, good morning, good day, good evening, wherever you are on the globe. So my task, you hear me? Okay. My task today is to give you my algorithmic approach to make a diagnosis of copper overload disorders. There are many copper overload disorders, but I'm basically focusing on Wilson disease. There are some very rare genetic disorders like Mednick syndromes and congenital disorders with glycosylation, which cannot cover those. I just like to make the most common form of copper overload is cholestasis. And so we cannot discuss PBC, we cannot discuss any types of secondary cholestasis. And obviously you have the problem of exogenous copper exposure. What I'm going to do is to use one patient history as a backbone for my presentation. These patients, a young lady, started to have increased transaminases at the age of 15. She was asymptomatic. She went to a physician, many liver diseases were exclusion. Finally, somebody did a ceruloplasmin and had a suspicion of Wilson's disease and referred her for liver biopsy. At this time, the ALT was 150, with normal value in our lab is 35. So plasmin was very low, serum copper was very low. She had no Kaiser-Fleischer rings. Her urinary copper excretion was in the normal range. She had no neurologic symptoms, and the fibroscan showed you 6.4 kilopascal for fibrosis, which is F1 to F2, and the fat content of the liver of 290, which equals about S2. So for all this, if you use the Leipzig score that I'm using throughout the presentation, she gets a score of 2 for ceruloplasmin. Now these are this is the first step. The first step is just do a clinical examination of the patient. Basically, you have to look for 3 things: the presence or absence of Kaiser-Fleischer rings. If present, you get a score of 2. For low ceruloplasmin, if it's below 10, like in this lady, the score is 2. And the presence of neurologic symptoms, if present, the score of 2. If you come to a score of 4, you have made the diagnosis, you need nothing more. Now, what about the Kaiser-Fleischer ring? You see here a very beautiful Kaiser-Fleischer ring, which can be seen with naked eye. It's a greenish brownish ring of the rim of the cornea. Obviously, it's better to ask your ophthalmologic colleague to use a slit lamp to look for it. And this is a study we did in Vienna. We had patients presenting with hepatic Wilson's disease, and in most of them, no Kaiser-Fleischer ring was detected, whereas in 95% of patients with neurologic Wilson's disease, there was clear-cut presence of liver disease. You can do it more fancier. You have here the so-called Scheimpflug video. What this equipment shows you is the Kaiser-Fleischer ring at the rim of the cornea. You can measure the size, the area, the thickness, whatever, make a graph over time. And you can see that in a Wilson patient with Kaiser-Fleischer rings, the signal is high, whereas in a Wilson patient without Kaiser, having controls, there is no signal. And you can use this procedure to repeatedly measure the patient. You see beautifully the disappearance of the Kaiser-Fleischer ring over time. Even more complex is occipital computed tomography. What you do here, see here, something really depends on what's available, not what has to be done. This is the retina, and you see the different layers of the retina. You see here is this, the ganglion cell inner plexiform layer and the inner layer. And you measure the thickness of these layers. You see here, there's a distinct difference in patients with Wilson's disease. So this is very good for research purposes, but it's not very useful for clinical practice. What about neurologic symptoms? They are common. The problem is a definition. Basically, that's easy if you have a neurologist to confirm that this patient has neurologic symptoms like tremor, rigidity, dystonia. But the psychiatrics, it gets quite difficult. An alternate approach to neurologic examination is an MRI of the brain, where experienced radiologists can detect typical signs of Wilson's disease in the brain. So if you have this and typical neurologic findings, you get an additional score of 2. The big problem is the psychiatric background, which now comes more and more in the foreground. And you see here the percentage of patients with some psychiatric problems in different parts of the world. It's quite astonishing. It's around 50 to 72%. And what do we find? The most common finding is a cognitive impairment, followed by depression, inappropriate behavior, and family problems. These are all data by Dr. Walsh. We just did a prospective study in 40 patients with mostly hepatic Wilson's disease and find some psychiatric diagnosis in 70% of them. So it's very hard to say, well, this is part of Wilson's disease, is it specific or not? So we do not give a point yet to psychiatric symptoms. What about ceruloplasmin? Ceruloplasmin is unfortunately a very poor test. It has a very low sensitivity and very low specificity, and is pretty useless as screening. Because ceruloplasmin level is increased by any type of inflammation, for example, if you have hepatic Wilson's disease, by the intake of female sex hormones and during pregnancy. So the most common wrong diagnosis, if they send me a young girl, she's stating the pill has a high copper content in the blood, and the patient, the physician doesn't know that the level should be low and thinks it's a high copper content. But on the other hand, ceruloplasmin level can be decreased by low copper supply, quite typical in celiac disease and malnutrition. Obviously, that's what you want to achieve on therapy. And in acute liver failure, you have a decreased hepatic production. And there's a different disease called aceruloplasminemia, which lowers your ceruloplasmin. So the problem is how to assess the copper. Now we have the patient back. Her score is 2. What's the next step? As I said, the next step is to make urinary copper determination, which was normal. This patient, the question is, what about her copper? How can we measure how much copper does the patient has in her body? Sorry. And there's a mixture of various pools, and you have to determine what is toxic out of this. You see here coins, and you just think you have to find a coin produced in Sweden, how difficult it would be to find it out. I do not want to discuss this cartoon. The point is that the blood copper, the exchange copper pool in the blood, is derived from the intake of copper, which comes from the food, release from the liver into the bile, which goes into the gut and may be reabsorbed, and also the export of copper to other cells using different carrier proteins. So what you measure is a very big mixture of a variety of things. So the first and oldest thing is to calculate the so-called NCC, or non-ceruloplasmin bound copper. I mean, I'll just give you one of the formulas. It's not so easy to calculate, but there are many, many calculators available on the internet. Basically, you take away from the total copper concentration the ceruloplasmin copper. It proved to be not very useful in patients with mild liver disease and asymptomatic siblings. And frequently you have even negative values. So it's not very useful at all. And that's why many people try to develop better methodology. And basically you have to understand that what you measure in the blood consists of two pools. Most of it is non-toxic because it's bound to proteins or to ceruloplasmin or to peptides. And there's a labile pool. It's not really free copper, it's a labile copper pool, which cannot be directly measured by using the NCC. We have new methodology. One is the exchangeable copper methodology, and then new copper. I just give you a very short introduction to these methods. This is the exchangeable copper. What you are doing basically is you incubate plasma with EDTA for 1 hour, do ultracentrifugation, and what's in the supernate is the copper labile pool, or exchangeable copper. And you see here, you just concentrate on this part of the slide. These are patients with severe liver disease, Wilson's disease. These are with well-controlled Wilson's disease, and these are controls. So what you see here, the separation is not very good. And therefore you calculate the percentage of copper as relative exchangeable copper, and then you have a very nice separation between controls and Wilson's disease. This looks very nice, but was not really validated in all patients. It has setbacks. The size exclusion is not physiologic. EDTR can also pull off copper from ceruloplasmin, so give you a wrong value. And if the pore size is not universal, regulation of what gets through may be imperfect. So it's a good method, but it could be also a miss. This is a very elegant method. The DNCC method basically means direct NCC measurement. What you have here are the 3 compartments: peptide-bound copper, albumin-bound copper, and ceruloplasmin-bound copper. By immunologic methods, you take away the ceruloplasmin, so you're left with the NCC, or this is what you get here. You see here the same slide again, that at the end you have a pool which is called labile copper pool. If you take all this away, and this is about equal to what you called free copper. You see that 40% have negative calculated NCC by the calculated methods. And the DNCC excludes negative values, can quantitate the range quite long, and includes copper bound to albumin and also to the drug of interest. And this is the final new method used in another study where you measure by an chromatography the amount of copper in various peaks, and you can see directly measure the amount of copper in ceruloplasmin, and you can derive your your amount of copper. Unfortunately, none of these methods has been very well validated. It's not available in many parts of the world, so it's more or less restricted to research studies. So we are still stick with the NCC methodology, which should not be used because it's very incorrect. So what can we do instead? What I think a good measure is the excretion of copper in the urine, because it really reflects the free or labeled copper in the blood, because that's what can be excreted in the kidney. And this only increased when hepatic and extrahepatic copper storage capacity is exhausted. As long as the liver doesn't release it, it's normal. And it is always very high when copper is released from necrotic hepatocytes in any type of hepatocellular necrosis. So in acute fulminant Wilson's disease, we have a large necrosis of hepatocytes. We have a lot of copper released into the circulation. Copper may be very whole. And urinary copper cannot be measured within anuric patients. Now, going back to the patient, we did now the urinary copper, which was normal in the patient. She's still with a score of 2. So what's the next step? This really depends on your local availabilities. There are basically the option to do a liver biopsy, which most of the people do not like to do, but I think this should be the method of choice. Or you have the whole possibilities of genetic testing, which is non-invasive, but time-consuming and very hard for interpretation. So basically what we did in this patient was a liver biopsy, but just follow my path. I give you the data for genetics in this patient. So basically where I can use this molecular genetic testing is to confirm suspected diagnosis, like adding additional points. It's not needed in patient where you have the diagnosis already. It's imperative to have it for family testing. This role in unclear diagnosis remains to be questioned, and it is not possible to screen for Wilson's disease by molecular genetic testing in a healthy person. So back to the patient, this is what we found. The patient had this particular mutation, the inversion in exon 8. This came from the mother, and the other gene came from the father, but we were not able to identify the paternal gene. So she gets a score of 1 for this purpose. Now, this is the procedure how to use genetic testing for diagnosis. It really depends. If you know the diagnosis, you don't need it. And it depends on how much suspicion you have for Wilson's disease. And if you know the have an index case and do family testing, you obviously test only for the detected mutations. And this is the sequence. It really depends on your local possibilities. Some variants are common in some parts of the world. For example, in Europe, it's the H1069Q mutation. In India, it's a mutation on exon 2. In the Far East, it's a mutation on exon 8. And if you have these mutations, you can make a multiplex PCR and look for these specific mutations. So if you find them, you have the diagnosis, but if you find nothing, that doesn't help you. Finally, you have to analyze all the 21 exons and sequences by saying a sequencing. And if this doesn't give you a result, you have to use more methodology. You have to analyze the promoters region and use specific methodology to find large deletions. So the end result of the genetic testing is then you find two mutations, then you confirm the diagnosis. If you find no two mutations on both alleles, then you have the option to use even more expensive and time-consuming testing. Today it's not NGS, which is very nice because it gives you a whole description of your genetic input of the particular gene, but it's very hard to explain what you found. And it's also time consuming. In our hand, it takes up to 1 year before we get back the result. And if it is all negative, then you may have to reassess the diagnosis. Now, this is what you can get. You get a particular finding, which you call mutation or more appropriate to the variant. And most of these variants are tested by functional assays. So I think if there's a common variant, you can do variants in yeast or whatever to look for the functional consequences. And if you find it, it's clear-cut pathogenic. Then you can compare the frequency of a particular variant in Wilson disease patients to the frequency in healthy subjects, at least in healthy subjects. And if there's far more frequent in Wilson's disease, it's very likely pathogenic. And today have several databases just mentioned here. I'm not going into detail. And the classification today is pathogenetic, likely pathogenic, likely benign, and there's large group in between, which is called the variant of unknown significance, the US. The problem is here, there are single reports from people around the world finding this variant, and nobody else found it. So I think if you find something in your patients, please report it to the appropriate site where you're working with. The big problem with all this is if you only find one ATP variant, like in this patient, what does it mean? Now, we did it as in our patient, we found one variant. So she gets 1 point. She gets 1 point. So her score increases to 3. Not enough to make the diagnosis. So the next step is liver biopsy. I think people are feared to do a liver biopsy. Hepatologist is a day-to-day tool. I think it's a very important thing to do. Obviously, you don't do it in small children. You don't do it if you know the diagnosis and if you have other methods to do it. But in a case like this, 17-year-old lady with abnormal liver values and low ceruloplasmin, you really like to know right away whether she has Wilson's disease or not, and not wait for 1 year for her genetic results. This is the largest study, it's a study from China. They analyzed 643 patients, and basically you see the different cutoff values. 250, the best was 168 of them had Wilson's disease, 15 had no Wilson's disease. Then is the gray zone between 50 and 250. There were still 10 patients who had Wilson's disease, and these are the patients with normal liver copper, and not a single patient had Wilson's disease. You see here a study of ours, where we did a synchrotron radiation microscopic X-ray fluorescence, and you see here the copper stained brownish in the liver, and you see here that the density of these nodules is different. So if your needle hits here, you get a very high value. If your needle comes here, the value is normal. And if your needle hits here, your value is somewhere in between. You have to do at least 2 passes. But besides measuring the copper content, you get a very important information on liver histology. And Mike Shilsky will tell you how important it is to have a good diagnosis and to assess the damage in the patient. You see a whole range of changes which may happen in a patient with Wilson's disease. You just have a typical nuclei with holes, steatosis. You may have a NASH-like picture. You may have a picture like at autoimmune hepatitis, or you have frank cirrhosis. Let's go back to the patient. We did the liver biopsy. She had chronic hepatitis, F2, fibrosis grade 2. Hepatic copper content was 1,330. She got a score of 2. And so we had the diagnosis. See here, from this pathway leads you directly to score 4. And we have established the diagnosis. Whether you used first the liver biopsy or mutation analysis is a choice up to you. It will more or less depend on your local facilities. But if you have done a liver biopsy, found no mutation, the liver copper is normal, then the diagnosis of Wilson's disease is very unlikely. You see here, so we've made the diagnosis. Unfortunately, the story did not stop here. This is a cousin of our patient. 3 years later, she developed jaundice and ascites. And you see here the values of January 21. She had a mild jaundice, high ANR, mild transaminases, but very importantly, very low alkaline phosphatase, which may be a sign of so-called acute liver failure. Unfortunately, we got no ceruloplasmin because she was treated in our hospital at the moment, and she had a Kaiser-Fleischer ring. So I make the story short. She underwent liver transplantation. She had a cirrhotic liver with a very, very high copper content. But she had another sister. She is an active neurosurgeon. She's absolutely asymptomatic and has no idea that she has a disease, but she at least volunteered to have some blood tests done, which were highly abnormal, as you can see here. Especially the INR was 1.6, the albumin was 32. The fibroscans give you 45 kilopascal, which equals F4, and some fat in the liver. So the liver histology confirmed the presence of cirrhosis, and she had a hepatic copper content high in the sky. Now, she was asymptomatic. It's very important. You see, she has a major tissue damage, but she's asymptomatic. Now, this lady is continuously an active neurosurgeon, doing her job very well, and on treatment, all the values have normalized. Now, going back to genetics, you see this was the initial patient. We found one mutation which came from the mother. In these 2 patients, we found also one mutation which came from the mother, but again, the paternal gene was not found. So then you go to the NGS, and that's what was the result of the whole genetic testing. You see here in blue, the mutation we found in the young lady. You see here in green, the mutation we found in the 2 sisters with advanced liver disease. And this is the black one, is the paternal gene. And basically, it was an intronic splicing variant, which was present in everybody. So this is bad luck if 2 brothers married 2 Wilson's disease gene carriers. This tells you that once you have made the diagnosis, you also have to look for the family. And the newest kid on the block for diagnosis, which has not been found its direct role into the diagnosis, is to measure ATP peptide in blood spots of patients with Wilson's disease. It's a methodology which involves several steps to isolate ATP peptide fragments. And basically, this is a study we did over the world in Austria, in Yale, in Seattle, and in Germany. And we had 180 Wilson disease patients, 218 Wilson patients, and in most of them, no fragment was found. Very simple, 1 blood test needed, nothing else. Unfortunately, that's 100% because you see here, 92% had no measurable ATP peptide, but unfortunately 8% had, interestingly, with very particular mutations. And if you just looked at the group where you didn't know clear-cut genetics, it was still 95%, and it was 91% in genetically confirmed patients. So it looks to be a very good methodology. Dr. In Seattle are working on this assay to make it even more reliable. But I think this is something we can apply for neonate screening, for example, whether it is useful in day-to-day screening. If it gets commercial, maybe it can be very useful. So the take-home message for my approach is, if you consider Wilson's disease in your patient, follow the algorithm. Use what is available at your working place. Without suspicion of Wilson's disease, do not test the patients for Wilson's disease. Thank you very much. Okay.
Thank you, Dr. Ferenczi.
Yeah.
I think we'll open the topic now to discussion, and I'll set the ball rolling by asking you the first question here is this. First of all, Dr. Ferenczi, we have had problems about diagnosing and looking at Kayser-Fleischer ring in patients who are usually having liver failure or are fulminant hepatic failure with Wilson's disease. So what is your experience of using handheld slit lamps for the diagnosis of Kayser-Fleischer rings in your institute?
I mean, that's basically what we are doing. So that's what's available. You cannot get an OCT. And also to get to the Scheinberg imaging, you have to move the patient to the ophthalmology department. So that's all you have. I mean, you have to rely what they find. I mean, that's the easy answer to this. I mean, that's the reality of life. If you see it, you see it. If you don't see it, you don't see it. Basically, it's a little bit dependent on the experience of the ophthalmologist. And there are sometimes discussion about this, but I mean, there's no way to optimize it.
Okay. Somebody else has questions, please put them in your question or Q&A box. I'll see them from there while I ask a second question to Dr. Ferenczi. We do see in adults, a lot of these adults are being diagnosed at 70 and 80 years of age. So how do you explain that? Why have they not presented earlier? What is there? Are they compound heterozygotes or heterozygous patients who have not just presented? Or is it that they are some normal or a milder variants who have not presented till 70 or 80 years of age?
Well, that's a very excellent question. My most recent case was a 78-year-old lady with hepatic failure, and she was diagnosed having Wilson's disease at the ICU. She had no evidence of any disease throughout her life. And I have reported this in a paper in gastroenterology, late onset Wilson's disease. Mike Shilsky has reported a case of a 72-year-old lady. We have no idea. I think basically, you have a genetic background, and you have an environmental background, and you have other factors which control copper metabolism beyond ceruloplasmin. I think in a very large study published in Hepatology 3 years ago, I published the genotype-phenotype correlations in more than 1,200 patients with European Wilson's disease. And we found there were only two factors which correlated with the phenotype. Was the age of onset and the female gender. For some reasons, females present more commonly with liver disease and males with neurologic disease. There may be several explanations, but none of them can be proven. But at least there's also experimental evidence. The sex hormones play an important role, and age obviously it's hard to define. I mean, it depends also on the physician. I mean, for example, I give you a patient They had a liver transplantation of 44-year-old male with Wilson's disease, cirrhosis and everything. And doing the history, found out that his sister died at the age of 10 of fulminant Wilson's disease. And he underwent appendectomy at the age of 11. And the surgeon said he has a cirrhotic liver. And that was it. Nobody did something. So what we don't know is the natural history of the disease. So it's nothing unusual. You have age is not a point not to look for Wilson's disease. Again, my oldest patient is 78.
Over to you, Dr. Jia.
Hello, thank you. I'm sorry for the technical problem. I just managed to get through. Zoom is a little bit difficult to use in China here. I'm sorry, but I just heard the latter part of Professor Peter Ferenczi. Professor Ferenczi, your excellent talk, really appreciate it. I have just a very maybe short question for you, if it is still okay. Now, this is, by the way, this is Jidong from Beijing. I hope you can see me now.
I don't see it, but I can switch you on, okay?
Okay, thank you. Haven't seen you for a very long time. Well, a short question about the fulminant Wilson disease. In recent years, we see some cases really very severe fatal cases. If there, of course, we in our center is a one-off center, is a center of excellence for liver transplantation, but not available in all centers in China or maybe other parts of the world. I just want a short question. Could you believe that some kind of intravenous medication for the corpora removing agents could be work for this kind of fulminant cases if there's no liver transplantation available? Thank you.
Well, Mike Shilsky will discuss this issue in his next lecture. But basically, my answer is several approaches have been tried. There's plasma exchange, the Mars equipment. We are currently using copper exchange dialysis. This is all experimentals, but I think you have to try what you get. I mean,
survival without transplant is rare. What you need to do is look at the dividing line between what we call severe acute liver injury and acute liver failure when encephalopathy and severe hepatic decompensation is present. The latter is almost rare, almost uniformly non-responsive. And what you do most of the time even with these advanced techniques is temporizing. It's very difficult in those cases.
Okay, thank you. Thank you. A very insightful comments and answers.
I think it's very
you.
important to understand that you can only use what you have.
Yeah.
I think, I mean, if you're in a major center somewhere in the world, you can use everything. If you're somewhere down in the countryside, the only thing you can do is to take your phone and call the center.
Okay, thank you.
Dr. Jia, there are some questions in the question answer box. We can take them at the end of both the sessions.
Okay.
So we've just done one session with Dr. Ferenczi. Yeah.
You mean we still have time for the next the remaining question, or at the end of talk, or now we answer the question?
May I ask one?
Those questions after Dr. Shelsky has spoken.
Yeah. So shall I just introduce Professor Shelsky?
Absolutely, go forward.
Okay, thank you. It's really our good honor to invite Professor Shelsky, who is the professor of medicine and also understand professor of surgery at Yale University, which is also the center of excellence for digestive disease, for hepatology, also for liver transplantation. Professor Shelsky's topic is also the same. My algorithm, my approach to the fulminant liver failure and also the conventional Wilson disease. Professor Silversky, please.
Hi, my name is Mike Shilsky, and I'm Professor of Medicine and Surgery at Yale University, Director of the Center of Excellence for Wilson Disease at Yale, and I chair the Medical Advisory Board for the Wilson Disease Association. I thank you for the invitation to talk to you today about an algorithmic approach to the treatment of Wilson disease. These are my disclosures. I'm going to begin by giving a brief introduction about a summary of Wilson disease and the pathophysiology, very brief, but this will set the table for understanding about some of our directed therapies towards Wilson disease. So this cartoon is of a liver cell, hepatocyte, and the Wilson disease gene, ATP7B, sits at a very critical point where it actually sorts copper when it's present in excess into the recycling pathway for excretion into bile. So you have this vesicular pathway and copper is excreted into bile, but it is also the same site where you have the introduction of copper into the secreted glycoprotein ceruloplasmin. So when you have the defective gene for Wilson disease, what occurs is not only do you have a reduced biliary copper excretion when the copper cannot get in that recycling pathway, you also have production of the ceruloplasmin peptide, but without its complement of copper. Therefore, in the circulation, it has a shorter half-life, and that's why levels are lower in our patients. But importantly, the liver, which is the sorting house for our copper metabolism, is in equilibrium with a pool that we call non-ceruloplasmin copper. So when you have an expansion of the pool of copper in the liver cells due to the reduction in biliary excretion, you have an expansion in this non-ceruloplasmin copper pool, and this is what drives up the increase in the urine copper excretion in these patients when they become more advanced, and certainly when they're symptomatic, as well as provides the copper beyond the standard extrahepatic copper utilization by other tissues. It results in tissue deposition, and in particular, we worry about the central nervous system, which can lead to neurologic and neuropsychiatric manifestations of the disease. Now, this is a slide showing the timeline of changes that occur in an untreated patient with Wilson disease, read from left to right. In an untreated patient, you first develop hepatic inflammation and then non-specific symptoms of liver disease, and ultimately you develop cirrhosis and then if you continue in time, you develop neuropsychiatric symptoms or complications of the cirrhosis and portal hypertension, and ultimately liver failure and death, whether it's directly from liver failure or complications of the liver disease. Either may occur. Now, an important concept is when you begin to think about these patients and the symptomatology of what they have, the treatment may be different at different stages of diseases. So we say the treatment goals are phase dependent for the disease. And this is a concept we've introduced into the latest AASLD guidelines, which are going to be published shortly. So when we think about treatment for Wilson disease, we consider that which is directed primarily at dealing with the excess copper, and that which is directed at the symptomatology as a result of either the advanced fibrosis and cirrhosis and complications of portal hypertension, or the extrahepatic deposition of copper into the central nervous system, leading to neurologic or psychiatric symptoms. Now, in the next few minutes, I will be focusing on the pharmacotherapy for Wilson disease. And our goals of therapy are initially disease stabilization and clinical improvement, certainly if there are symptoms present. And then long-term, once stabilization is achieved, prevention of new symptoms and continued stability and hopefully no disease regression. Now, when we start to think of how to approach this disease and in an algorithmic fashion, in each and every algorithm phase, we have to, one, make sure the diagnosis is secure. It will do no good if you have not fully secured the diagnosis and you continue to treat a patient. And this, again, because you're considering lifelong therapy, is very important to make sure it's well established. And my colleague, Professor Ferenczi, I'm sure will have given great detail about how to establish the diagnosis for our patients. Now, once we do determine the patient has Wilson disease, next thing is to really think about what stage of disease they have. And we put patients into the following categories. They may be asymptomatic, as defined as no clinical symptoms, but importantly, also no tissue damage. And then there's another interesting category of patient who may not have clinical symptoms, but start to develop tissue damage. And I think we start to think of approaching these patients slightly differently than those who are in that first category, asymptomatic, but without tissue damage. And then we have symptomatic patients with clinical disease, and then symptomatic patients with more advanced disease. And then infrequently, we can have a fulminant presentation with acute liver failure, which indeed is really an acute on chronic failure, as these patients have clearly had Wilson disease from their birth. Now, how do we determine if there is tissue damage? And again, that's important because we want to divide that first phase of a patient who's asymptomatic into those with and those without. Now, use of our biochemical tests from the blood sometimes can make it difficult. It's really more specific if there is altered function, and we see that from our biosynthetic function in INR and albumin. And if we are to do biopsy, we can see inflammation and development of fibrosis. Over the last number of years, we have had the tools to begin to look at non-invasive estimates of hepatic fibrosis, elastography, and other serum assays. And we believe these do have value, although they need to be better established with respect to the parameters for Wilson disease. But certainly the presence of fibrosis, whether or not it's seen on biopsy or seen indirectly through use of elastography, may be very valuable, and again helps us separate that patient into that category of tissue damage. Now, imaging of the liver can be very helpful too, and this may show fatty change or morphologic evidence of advanced fibrosis and cirrhosis and of portal hypertension, and clearly that helps us put the patient into that latter category. Now, if they are asymptomatic and have no tissue damage, then we look at the age of the patient. If they're at the very, very young pediatric patients of less than 3 years of age, we may choose just to monitor because it's important to have growth and development occur normally and not interfere with copper metabolism during that time. Only if there are inflammatory changes or evidence of any tissue damage at a young age, and this can be looked at non-invasively or by biopsy if necessary, then we can begin to consider treatment. Once they're over 3 years of age, and certainly the majority of our patients are found later on, then we would initiate treatment. We would advise a low copper diet. And with respect to pharmacotherapy, if there is no tissue damage, in my mind, we can look at these patients very similar to how we look at a patient who's already achieved good initial therapy completion and disease stabilization. That, as I look at it, is equivalent to a maintenance therapy and preventing the asymptomatic patient from developing symptoms. For this, a patient may be treated with zinc, and this is any of the zinc salts. And if they are pediatric age, it would be 25 milligrams 3 times daily, separated from food. or if they're beginning to be adolescents and older, 50 milligrams 3 times a day. Or very standard treatments, maybe with chelation therapy. And typically we would like to think of the same dose for these individuals as we might for a maintenance therapy, and that would range between 10 to 15 milligrams per kilogram, whether with D-penicillamine or with trientine. Now, if they are asymptomatic but have, with respect to clinical symptoms, but have tissue damage, then I still think these patients need to move into that same category as a symptomatic patient. And so in these individuals, we probably would be less likely to consider zinc, although it has been used for some in some studies. And I think chelation at a higher dosage, 15 to 20 milligrams per kilogram, initiated over a 2 to 4 weeks time, may be a better option for some of these individuals. And then you are going through what some term a decoppering phase, that is removing the labile copper pool, reducing that non-ceruloplasmin and copper, allowing healing to occur and reversal of symptoms and tissue damage. Now, if a patient has clinical disease, and again, it's extremely rare to see that less than 2 to 3 years of age, then these are patients you want to initiate treatment, as we mentioned, with diet, but with respect to pharmacotherapy, truly these are patients probably best off treated with chelation first. And also, if they have extrahepatic symptoms, directed therapy to address those issues, for instance, portal hypertension, use of non-selective beta blockers, or severe tremor. There are some agents our neurology colleagues prefer to use, as well as treatment of depression and or other psychiatric symptoms, using appropriate pharmacotherapy, paying attention to the state of their liver disease, and making care that the choice of agents to treat that are liver safe. Now, the doses of these medications should be the initial therapy dose ramped up to 15 to 20 milligrams per kilogram over a 2 to 4 week period of time, and then patient followed on that therapy. Now, the big question often comes up, I've started an initial treatment on my patient. When do they actually reach that point of maintenance therapy? And the key is there is no exact time date. Each patient may be slightly different, and that is partly because of the heterogeneity of the disease, due to both genetic and extragenic factors and environmental factors. And in these individuals, you find disease stabilization often occurs between 6 to 18 months. So during that course of time, it's important to watch your patient clinically for ongoing improvement of any symptoms. Look for biochemical stability, improved or maintained synthetic function of the liver, and reduction in aminotransferases. They may not reach normal in every individual, but they should be trending towards improvement, as well as an improvement of bilirubin if it was elevated at the start as well. Now, for patients on chelation therapy, urinary copper excretion should be reduced into a range for chelation somewhere around 500 micrograms and less than that. And for zinc, typically should be less than 100 micrograms in a 24-hour period. Now, maintenance therapy implies, if the patient was on an initial higher dose therapy, a reduction in the dose of chelation from that 15 to 20 down to a 10 to 15 milligrams per kilogram. For zinc, we don't recommend changing dose unless patients start to show signs of a later, and this typically occurs in years, not typically in months, of showing signs of a depletion of their copper pool. In that case, they would have a very low urine copper excretion and a low serum copper, and may start to show signs or evidence of neutropenia or further thrombocytopenia, as well as develop a sideroblastic anemia. This can also occur with chelation therapy if over-applied as well. Now, 5% of our patients with Wilson disease may present with acute liver failure. The classic presentation is that of a non-immune hemolytic anemia, where the patient rapidly develops jaundice, both from the liver disease and the accelerated hemolysis, causing indirect hyperbilirubinemia in a high percent as well. They may develop ascites, and renal failure may occur due to release of the copper complexes and acute tubular injury to the kidneys. And in these individuals, this is typically a very rapid course. The majority of these patients have either stage 3 to 4 fibrosis of the liver at the outset. So it is not on the background of no liver disease. For that reason, many of these patients may have low aminotransferases. The diagnosis is important to establish this, and we can do that, as I'm sure Dr. Ferenczi has spent time talking about the presence of hemolysis, the AST-ALT ratio, alk-phos to bilirubin ratio, as well as elevated serum and urine copper. And we had looked at this years ago. Jessica Corman was the first author of a hepatology paper, and we had found a fairly good diagnostic predictability by looking at both the alkaline phosphatase to bilirubin ratio and AST to ALT ratio as well. I'll not belabor the diagnostic part, but I do want to jump in and talk a little bit about the treatment. Again, you want to differentiate this from other non-Wilson's treatment, although these patients may be destined for, many of them, for liver transplantation. And still, it's important to know the diagnosis of Wilson disease, because then you would do the family screening appropriately and try to prevent the same in other family members. Now, importantly, when you see these patients with this presentation, to decide how to approach their treatment, we do use a prognostication model. And the one I favor is the modified NASER, or the King score. And this really divides patients into whether they should have medical therapy, which in this case we would deem a rescue therapy, or they should undergo a rapid evaluation for liver transplant and transplant when an organ is available. Now, this work was done by my colleague, Professor Dewan, and his colleagues at King's, and it really was very important work. And they had a cohort of individuals which were not eligible for liver transplant and looked at all the parameters in these, and then conducted appropriate analysis. And when you look at the area under the curve for each of these, you come up with these particular variables, which were helpful, and each is given a weight based on the value. So the serum bilirubin, AST, INR, white count, and albumin, which also account for the acute phase and sort of a SIRS-like reaction that can occur in these individuals. And that's the advance compared to the prior NASER score. But when these individuals have a score of 10 or less, they can most of the time be successfully treated with chelation therapy, and above 10, typically these patients require transplantation. Now, these are not etched in stone, and I've seen patients on both sides of the curve go on to be either successfully treated medically or require transplant. And the key, I think, is knowing that if you look at this at one point in time and you follow how your patient's doing, then the key is looking again at that next point in time and considering to look at this serially, in which case it may be even more predictive if the scores are rising. You're not going to really be successful most of the time. Whereas if your score is dropping, then that may be very helpful. You have to be careful that the parameters are not confounded by things like transfusion of FFP or other factors, which may change some of the parameters that we're looking at. Now, so how do we stabilize these patients with Wilson disease and acute liver failure? There are a number of different things that have been reported. Each of them have their benefits. And really what I suggest to people is find what your local hospital does best and use that effectively for your patient. Whether it's plasmapheresis or exchange, hemofiltration, if you have available albumin dialysis, gives you a sink to place that extra copper in, or a Mars device, which is basically a combination of a recycling albumin circuit on hemofiltration, in which the copper is extracted by anion exchange and charcoal, and sort of rejuvenates the albumin, and then it can go back for another cycle. But any of these that you do will really be, in most cases, temporizing, and you're buying time and trying to improve the status of your patient awaiting an organ for transplantation. Now, in the last moment, I'd like to kind of put this all together for you in one sort of algorithm. And again, we look at patients either asymptomatic, symptomatic, or the rare patient with acute liver failure. So let's go down the asymptomatic arm first. We assess for tissue damage. If there's no tissue damage present, then we go down to the equivalent of maintenance therapy, a lower dose chelation, or zinc, dose dependent on the age of the patient. If the patient is symptomatic, we consider that we, again, assess the degree of tissue damage, because that may also influence, again, if they are cirrhotic with portal hypertension, there may be other additional treatments that we want to do. Similarly, if the patient was asymptomatic but had tissue damage, we go down this same pathway and we initiate chelation therapy at the higher dose, 15 to 20 milligrams, over that, ramping that up over the 2 to 4 week period of time. Our aim for this is to stabilize clinical and biochemical parameters, but if we meet with a treatment failure, then these patients need to go to a rescue therapy. That means potentially in a more intensive regimen, sometimes even combining treatments, zinc and other chelation temporarily separated, and then looking at that patient very carefully, because then if they start to fall within that prognostication score of greater than 10, that patient may then be considered down the same arm as those presenting with acute liver failure and may need to go the transplant pathway. If we see somebody presenting with acute liver injury or acute liver failure due to Wilson disease, we look at that prognostic score again. And again, we try either that very intense medical therapy or we go down the transplant pathway. Now, I'd like to acknowledge the committee of the American Association of Study of Liver Disease for their willingness to consider a multidisciplinary guidance, which we are pleased to say has been accepted and should be out and available for people in the very near future. The Wilson Disease Association, which supports our patients and has also worked with us to support a registry project, and our colleagues at Yale, where we have a multidisciplinary team involved in the care of our patients. So thank you for the opportunity to speak with you all today, and I look forward to taking any questions. Thank you.
Okay. Dr. Gia, can we now start?
Yeah. Okay.
Okay.
Can you hear me now? Maybe my connection is not very good. The sound is a little bit interrupted.
The question answers? Can I ask the
Yes,
question answer session? Okay.
Yes.
So for Mike Shilsky, thank you, sir, and good evening for us and good morning for you. I just said this ball rolling. After a long time, I've heard people talk about the combination therapy, that is the zinc plus chelation therapy, and especially you said so for the group which is in acute liver failure. So you feel that this should be only tried in this small subgroup, or do you say that in all those who have tissue damage, you would like to use the combination therapy?
No, I think the combination therapy is more
it's put up doses apart from the meal.
Yeah. Now, the combination therapy is more complex for patients to take. It requires multiple doses separated from food and from each other. And so I think we reserve this for patients who have severe decompensated disease. And I think that in that case, it warrants the extra effort to try to help those individuals. Now, there are other rare times where a combination may be helpful, almost used like we do in autoimmune hepatitis, where we use other immune suppressives as a sparing agent for steroids when we have either less available chelation agent, or in cases where we're worried about introducing chelation agent with severe side effects, especially the early neurologics. There, sometimes you can use combination and just ramp it very, very slowly. But for the most part, I try to keep it simple for the patients. And unless they have very severe disease, I usually try to keep monotherapy, one therapy, use it well, make sure it's working for the patient before going on to consider combinations.
Okay, so there are quite a few questions now in the question box. Some of them will be for Dr. Ferenczi and rest for you. So I'll quickly take those questions. Dr. Ferenczi, there are two of them who have asked if there's any role of, whether you would prefer a fibroscan or a shear wave elastography in assessing the fibrosis in Wilson's disease.
I would certainly do the shear wave elastography if I have the access to it. So, as I said, I think use the best available methods locally available. So I think we have published a paper on fibroscan. There's not much of a change as expected. This was quite surprised for me. With a follow-up of up to 20 plus years, nothing has changed. So that tells you that we have no idea about the sensitivity of these assays or these tests on the progression of liver disease. I think the fibroscan gives you only one answer, which is basically the stiffness of the liver, which is influenced by fluid, which is influenced by blood, and so on. So I think the better your test is, I would do an NMR scan if I have the possibilities to do so, because this gives you most of the information you can get.
Yeah. So for Dr. Shilsky, there's a question there that if you have a patient who's developed nephrotic syndrome because of deep penicillamine, so what would you be your change of plan B for this patient?
Well, first thing, stop the deep penicillamine. And second, I would probably consider zinc therapy for that individual. There has been potential use of trientine. It may be not as available, but we don't know in patients who've already developed a reaction to penicillamine what the frequency of reactions to trientine is as well. So probably in the beginning, I would favor zinc for that individual. And then if they still show inadequate response to the zinc, then reconsider, if trientine were available, substituting that.
So there's one more question that somebody's asked is there any role of total plasma, which you have mentioned here? They're talking of total plasma exchange in fulminant Wilson's disease leading to acute liver failure. So would you like to answer that again? Because there's somebody who's asked this question.
Yeah, I think there has been some evidence that it may be helpful for liver, acute liver failure in general. And in Wilson disease, the particular utility of whether it's total plasma or exchange or filtration is that what you're doing is lowering the copper acutely, so that you then break that cycle of hemolysis. And hemolysis is bad both for the loss of the oxygen carrying capacity, but also you release heme iron from the red cells, and heme iron is actually taken back up in the liver and it's toxic. So you actually generate this sort of recycled injury to the liver. So you really want to break that cycle if possible. And also when you reduce that copper, you also help your kidneys, because the kidneys suffer from the release of the toxic compounds, copper metallothionein complexes, which are released into the blood and cause acute tubular injury to the kidney as well. So you're trying to prevent further kidney injury as well as break that cycle of injury to the liver.
So there's one more question. Rajiv, I'm not taking your question. It's a little too long for us to take it up here, but there's a question from Pragati Grover who wants to know what is the experience with trientine in neuropsychiatric Wilson's?
The answer is it works, but there are no real good head-to-head studies which compare using one agent to the others in that particular population with more advanced symptomatic disease. There's going to be released shortly a head-to-head study just showing non-inferiority in a stable patient of patients on D-penicillamine with use of a trientine compound, but that's a very different population, and so it's very hard to say with confidence one is better than the other. But familiarity with using the medication, availability in the location, cost of therapy, all of these come into play, as well as the experience of the treater and comfort level of monitoring patients on the therapy is very important.
Yeah,
I think-
sorry.
Peter, please share your experience.
I think I just went through the most recent data on these different disease drugs. The mode of action of trientine and D-penicillamine is quite different. D-penicillamine is basically working in the blood. Trientine is a poorly absorbed drug. So 90%, 80%, 70% remains in the gut and acts like zinc. So it just binds copper in the gut. So I think you have to understand that these pharmacokinetic studies are worthless if you don't do it appropriately in patients with Wilson's disease. I think there's a very new idea coming up, was published in Hepatology, and there's a very nice study from Italy in gastroenterology, that trientine is a very good regulator of our autophagy, which is a very, very important point. And I think there's good evidence that, evidence is too much. Our ideas, it's a study in JHEP suggesting that the mode of action of trientine is not so much a chelator, but autophagy induction drugs. So I think we have really to think about not equally about the penicillamine and trientine. We just submitted a study to APASL where we have 31 patients who were receiving trientine from the start on and received it over up to 45 years, and they did very well. So it was clearly a selected group of patients. So I'm not saying it's substitutes a controlled study, but I think the point is you should be aware that D-penicillamine is not trientine.
Yeah, no, there's actually, thank you for mentioning that, Peter. There are some nice studies that hopefully will be shared more from the group in Aarhus looking at the uptake and kinetics and of each of these treatments and using PET imaging. And I think that will advance our knowledge as well. I saw there was another question about new therapy, so I'm going to just jump the gun for you and just try to step into that real briefly. We're waiting for further information from the analysis of the phase 3 study for the tetrathiomolybdate. So that hopefully will be available in the near future, and that will help us decide how that compares to our current standard of care therapies. Gene therapy studies are just in the beginning now. I know in the last meeting that came out of the group in India, there were some also alternative ways of approaching that. So I hope that we'll hear more about that in the future. There's a very exciting chelator that's being tested that seems to rescue mitochondrial injury called methanobactin, and that still has not yet jumped into human trials, but that is an IV administered compound which actually seems to lower copper in the liver very rapidly and may actually induce hepatic biliary excretion of the copper. So we're waiting for more information about its mode of action and its human trials, because that may be complementary to some of our other ongoing therapies. So not everything needs to be considered as one or the other, but as Peter pointed out, there are other off-target things that may be very helpful, whether it's autophagy or whether it's related to dealing with oxidative injury in cells, which we know the heavy metals promote, that when we start to consider how do we finesse the therapy beyond just the standard therapy, especially for those difficult to treat patients, these new modalities and extra sort of different pathway modalities may be very exciting for the future.
I just make a comment to you, Michael. You said you have assessed the tissue injury, which is very correct. As a hepatologist, we all understand what you mean, but what about the neurology patients?
That is a great challenge. I still believe a lot in the clinical examination from our movement disorder specialists, because as we know, the imaging, even though people have tried to create scales for imaging, I usually divide it into two categories, either findings present or those with, just terrible disease where you have literally holes in the brain from injury, and those patients tend not to get better. The others, all bets are off. You don't know whether they're going to get better or not. Just time will tell on treatment. And I wish we had better prognostic. We tried to do a pilot study with fMRI, which I think we need to follow up on, because I do think the neural pathways are affected, and that over time, that may be one way of looking at it. I know you've had other ways of looking at the neurologic injury in the past, I'll let you describe that, but I think these are, all of these help us. Now, there's been some work by Oliver Bamman's group in England looking at some of the injury proteins that may circulate in the blood and other factors, which may go up in the face of neurologic injury. And so whether or not we can generate sort of a panel of these kind of factors or cytokines that may help us track and prognosticate the neurologic part, remains to be seen. But that it's a lot more challenging. It's easier below the diaphragm, as you said.
No, I think the reason I asked, because you said that if you have no tissue damage, you can use zinc. Now, in the neurologic patients, you have definitely a tissue damage. You may not assess the dimension.
Well, yeah, I think clinically is the most important, but even, our colleague in Poland, Dr. Slankowska, even with the patients with some neurologic damage, has published successful use of zinc therapy.
The Dutch people.
Yeah.
That's, I think, a very important point to make, that you just think on the liver. It's not just the liver biopsy we have to do.
Well, I don't think people are lining up for brain biopsies.
No.
Dr. Kadir has a question. Do you, Dr.
Yes.
Kadir, have a question?
Thank you. This is Kadir Dökmeci from Turkey. Thanks to Professor Ferenci and also Shiski for their excellent presentations. Actually, Professor Ferenci pointed out that especially the genetic studies showing the mutations, very important for the diagnosis of the Wilson disease. There's one issue. The patient was diagnosed by, clinical symptoms and urinary and also serum copper, and also for the liver copper, showing the exact diagnosis of the Wilson disease. Still, do we need to make an analysis for the genetic mutations?
Well, I think I made it very clear in my presentation. You have to ask yourself why you need the genetic information. For these patients, for diagnosis, you don't need it. But he has a family with 10 children. It may be very helpful to know the mutation, because then you test them in 1 week. So, and I think it's really, if it's a single patient without any siblings, there's no need to do the. It may change in the future when we have gene therapy. So, but we cannot know exactly at what stage we are going to need genetic testing for gene therapy. How precise will be the replacement of the affected gene? I will attend a meeting in 2 weeks on a particular Spanish mutation. And yeah, I think You have to ask yourself, why do I need a genetic testing? I don't mind to do test patients with Wilson's disease. What I hate is that please exclude Wilson's disease. I never do the tests again. I refuse to do it.
Thank you.
Dr. Shilsky, there's finally a lot of questions pertaining to two things, I think. If you have a mild liver disease with neurological involvement and you have a cirrhotic patient with mild neurological involvement, can you just come back and tell us as to what would be your line of action in these patients?
That wouldn't change. I think, how you monitor them clinically would, because obviously you might focus on the liver in one, you'll focus on the neurologic in the other, but these patients we treat the same because the basis of the disease is the copper deposition into and out of the liver. So, these are patients that we put into that symptomatic category. And the only patient I might consider something different for is if they are failing to respond to therapy, then you have to consider whether they fall into that mode of a rescue therapy and require more aggressive, maybe dual courses of treatment, whether by two different agents. But otherwise, I would approach them just with the same symptomatic dose, 15 to 20 milligrams per kilogram of chelation as primary therapy.
Dr. Jia, are you okay with asking questions now, or are you?
Yes, I'm okay, but I'm afraid the timing is not almost at the end of the predefined timeline. Maybe the very last question about which kind of patient with a neurological manifestation should not offer liver transplantation. I think this is a controversial issue. Maybe both professors can give a very brief statement or comment on this.
I think this may be one time we agree, Peter, right?
Yeah.
Patients with liver failure and neurologic disease should be transplanted. There is no study yet that has looked at both comparatively medical therapy versus transplantation. Where I am, livers are not easy to come by. And so we save them for people who we can save their lives with. And if we can treat somebody medically, we prefer to do so.
Well, I think there's no evidence really that neurologic disease gets better. But what happened around the world was they made the diagnosis and sent them the patient for liver transplantation without even trying to use conservative medical treatment, and that's wrong.
Okay. Thank you for your comments. I think this is a very important question. But due to limitation of time, I think Dr. Lam would like to just briefly wrap up and just close the session.
Thanks a lot for this brainstorming session between. Can you hear me?
We can hear you.
Yeah. Yes. Yeah.
Okay, so thank you for this session on both diagnosis as well as management of Wilson's disease, and I can see the lot of excitement that I can see among my colleagues in the question and answer session. So both of you have done that to all of us, and I think we should soon have a more, like Dr. Shilsky mentioned in the end, there are some new prospective, exciting subjects to discuss in the management of Wilson's disease, and we should have a session on that very soon. Thank you very much, both Dr. Ferenczi and Dr. Shilsky. Thanks a lot for being here today.
Pleasure.
Thank you.
Wish everybody well.
Okay, thank you. Thank you, Professor Dr. Messi.
Thank you,
also.
Dr. Jia. Thank you,
I'm
Dr.
sorry for
Khalid,
the
and thank you, Dr. Jia.
Thank you, Ferenczi, Shilsky.
Okay.
It was excellent.
Thank you.
Excellent.
Thank you all. Thank you all.
Thank you
All right.
all.
Keep well now. I gotta go run.
Mhm.
It's too early for you, maybe.